Bariatric Happy Hour. I'm very, very happy to say that we have someone special joining us. Dr. Janey Pratt will be talking about the ASMBS pediatric and adolescent guidelines tonight. But first, a couple announcements. So you guys know ongoing, we'll still be having the fellow project on Friday morning. So the next session will be on the 2nd of August. 7 a.m. Eastern time, and I think it's 2 p.m. Eastern time is the repeat or afternoon session. The next Bariatric Happy Hour will also be happening in August. And actually, this is the last session that Laura Fischer and I will be leading. It will be taken over by Dr. Juyeon Park and Dr. Faiz Shariff, who will be joining us tonight on the panel as well. So let's start with tonight's session, just with a quick intro about Dr. Pratt and Dr. Schmiederer, who's our fellow, who's also joining us tonight. So Dr. Pratt is a general surgeon who specializes in robotic hernia repair and adolescent metabolic and bariatric surgery. She began her career in general surgery at the Mass General Hospital, where she was a founding member of the MGH Weight Center. As surgical director, she introduced MIS bariatric surgery and adolescent bariatric surgery to MGH. She took over as the director of the MGH Weight Center in 2011 and continued to work on several national committees toward improving access and care of adolescents with severe obesity. In 2016, Dr. Pratt moved to California to work at Stanford University. She performs MIS bariatric surgery at both the Children's Hospital and the Palo Alto VA. She's trained in robotic surgery, as I mentioned before, and she also does complex abdominal hernia repairs. I'd like to welcome Dr. Pratt and also to Dr. Ingrid Schmiederer. I hope I got your name right. She's the current fellow at Cleveland Clinic, main campus in MIS bariatric surgery. She completed her medical school at Drexel University and went on to do general surgery residency at New York Presbyterian in Queens. And she will be starting her presentation tonight. As usual, we'll start with a quick summary of the paper. Maybe not so quick. I don't know, Ingrid, if you have a lot to say. Followed by some commentary by Dr. Pratt. And then everyone can chime in. If you guys have questions at any point, please post them in the chat or in the Q&A, and we'll get to either bring you on the panel or ask your questions on your behalf. All right, Ingrid, go ahead and take it away. You're muted.
Right. Perfect. Great. Thank you so much. I will bring this
I'm
up.
so sorry. There's one other thing I have to say because I'm not sure if everybody will be paying attention at the end. I do want to thank James and Morgan and the ASMBS team for supporting us throughout this year, or I guess the last couple of years. They'll be continuing, but Laura and I will not be on the next session. All right, great. Sorry about that. Go ahead.
No problem. Great. So I'm going to bring up my screen here. So thank you so much. As Julianne said, my name is Ingrid Schmiederer. I'm currently at Cleveland Clinic main campus. I am one of the bariatric surgery fellows. So I'm coming to you live from Cleveland. So we're going to talk about the pediatric and adolescent metabolic and bariatric surgery guidelines. The initial guidelines were set in 2012, and they have since been updated, and we'll be talking a little bit about the updated guidelines today. But just for some perspective, in 2012, they reviewed specific areas around, basically, as to be expected, around the prevention and guidance around obesity-related morbidity and mortality. They looked at criteria for adolescent bariatric surgery and patient selection. They based it on, much like adults' guidelines that we have, BMI, and this is something that will be brought up and changed a little bit later. BMI of 35, or should they call it 99th percentile? That was both of those, that wording was in the those guidelines. And then there was a list of the comorbidities which would benefit or which would be improved after metabolic surgery for these patients. However, at that time in 2012, the data was still ongoing. And in fact, at that time, they were recommending the two procedures that were talked about most were the bypass and the band. So what has happened since 2012? Well, the big thing that happened from 2012 to the new guidelines that will be mentioned in 2018, cell phone ownership and usage went up, according to, this is from PBS. So with that, and one could argue that also came more of a sedentary lifestyle, not only among adults, but also especially among adolescents who were taking part in social media. That also has grown exponentially since 2012, from 2012 to 2019, which is again when the guidelines are updated. Netflix had just started. It was still on DVDs. Social changes were occurring where there were changes in standards, there were changes in laws, and there were even changes in how people looked at themselves and how they looked at their role models, like in the 2016 Tokyo Olympics. Speaking of Olympics coming up. So 2018, so now as all of that has changed and all of that has evolved, in 2018, there was an acknowledgement actually that the guidelines needed to be updated. And in fact, it wasn't until 2013 that obesity was recognized by the American Medical Association as a disease. So then that opened up an increased research in the field. So with that, the guidelines also needed to be updated. So there were a number of prospective studies between that time that looked at long-term outcomes, looked at cost effectiveness, looked at improvement in quality of life for these patients. And what the authors for the new guidelines did was they did an extensive literature search using PubMed. They looked between January of 2009 and October of 2017. Search terms included weight loss surgery, pediatrics, adolescents, gastric bypass, sleeve gastrectomy, which had now increased in popularity, sleeve gastrectomy and laparoscopic adjustable band, as well as extreme obesity. So these articles included meta-analyses, randomized controlled studies, cohort studies, case reports, and prior systematic reviews with expert opinions. So with all of that, we were able to look at not only the research and the evolution of the science, of the evidence, and also the social implications, but we've also really been able to update that approach using all of these arguably new factors. So the first thing that changed for the guidelines, and I think a really overarching theme here, is looking at the vocabulary and the classification and the descriptions of patients moving forward. So rather than giving these patients, these growing adolescent and pediatric patients, a strict BMI, the recommendation was that it change based on growth charts. So these growth charts are taken from the CDC, and they have been most recently updated as of 2012, to include BMI of 60. But what the recommendation has been to look at the percentile of weight, and where these patients fall when it comes to their age group, and also their height and all of that, which may be different among, as we know, among children or adolescents. And then going into the meat of the paper or the meat of the guidelines, the same vocabulary and the same outline went going forward with the different comorbidities. But this time with these new guidelines, there was a lot more evidence. There was a lot more literature because there had been that time, but as obesity, not only as obesity had increased in incidence in the country, but also as metabolic surgery was really taking hold after its acknowledgement and after its increase in accessibility and popularity in that decade. So it looked at cardiovascular disease, diabetes, sleep apnea, and then there were other comorbidities that were really added on, or the vocabulary or the descriptions or the effects were described a little bit differently in these guidelines as opposed to 2012, looking at fatty liver disease, orthopedic disease, GERD, and even the intracranial hypertension, which had previously been mentioned as pseudotumor cerebri. What I really appreciated, and it's something I really hope we will talk a little bit more about, whereas that within these guidelines, there was much more of an acknowledgement on the quality of life for these patients, the quality of how the surgery will affect their lives, but also how their lives will affect their surgery and their outcomes. So it looked at the reports from adolescents themselves indicating that there's an impairment to their quality of life. There were not only things where there were social implications, but also physical implications of the seats at school or on the bus. And I think a lot of this really fed into mental health and how that might affect not only patient selection, but also the surgeries and the compliance for the patients moving forward. Same thing with family factors. Maltreatment was a factor to look at with the guidelines that I thought was interesting that they expounded upon the fact that children who were more like, there was a correlation between maltreatment and mistreatment in childhood and development and propensity for obesity in adulthood. And I think that's something that would really affect not only the outcomes, but also the selection and the process for this patient moving forward. Other issues were substance abuse as well as disordered eating. There was an acknowledgement that these also do correlate with the age range. This age group does have a risk and a propensity for these disorders or these changes in their lives and their standing. But it was this related to the surgery, and I think that requires more ongoing research. The next step was looking at a treatment plan. There was a discussion about informed consent. These patients, to be considered an adolescent, is between 10 and 19 years old. So for the majority of these patients that fall into that group, they need to be consented by their adults. They need to have assent where they can agree. They can have their own opinions and obviously their own autonomy, but ultimately and legally, the patient's parent would be making the decision. So there was a thorough discussion of risks, benefits, and again, with these growing and maturing patients, looking at compliance before and after the surgery, how that might affect this procedure moving forward. The operations were updated. There was some discussion of the switch and the SADI, although they did indicate that needed more research. There's new medications. This is pre-Ozempic, but they talked about metformin. They talked about Topamax, these medications that could benefit these adolescent and pediatric patients moving forward, and perhaps that might have a larger effect on the operation that required more data. And finally, nutrition. Again, how compliant were the patients going to be after surgery when it came to taking their supplements, keeping on top of their hydration. All of these required a strong multidisciplinary team and a strong partnership, not only with the patient, but with the parent. And I really appreciated this in all of the guidelines, that there was this focus on the psychosocial, the determinants of health, the implications of what this might mean for adolescent patients in this time, in this era of everything going on socially and in society. And then with that, description of multidisciplinary teams remained consistent between 2012 and 2018. And then there's going to be more from here, looking more at this transition into adulthood and the benefits and risks of this surgery as it relates to something like pregnancy or nutrition or growth, how that might affect the patient moving forward. I think that remains to be determined, but I think these guidelines really set a good basic framework for adolescent metabolic surgery moving forward. Thank you.
Thank you so much, Ingrid, for that great review of the guidelines. So there were a lot of changes between 2012 and 2018. The first guidelines I wrote was in 2005, and there was significant change between 2005 and 2018. And actually, we're working on the next set of guidelines right now, which we hope to get out next year. I think that what really made these guidelines important was that the teen labs data had just come out. So teen labs is the largest multi-institutional data looking at pediatric patients undergoing bariatric surgery. And it was predominantly bypasses and sleeves, although there were some bands in the beginning. I think they were dropped from the database eventually in the long-term follow-up. I mean, they weren't dropped. The data was presented, but it was horrible. So, but they did look at sleeve and bypass and saw really great results. And that was one of the prompts. Now, what's the prompt to do the next guideline renovation is that we now have teen labs 10-year data, which we expect to be published in the next year. It was presented at ASMBS in 2023, but it still hasn't been published. So we're waiting for that to be published to finish our final our next guidelines. My final one. I'm done after this. But it's interesting because writing guidelines is a very important part of what we do as surgeons. But the most important thing when you're writing a guideline is to recognize that it's going to be read by not just surgeons and not just patients, but also insurance companies, hospital administrators. And you have to be careful what you say. If you say this operation should never be done, that's never going to be done. And so you even when we wrote the 2012, the sleeve was just coming out. We didn't know anything about it. And we had to be very careful on our verbiage around the sleeve. And, in 2012, we didn't talk about it a lot because there was no data in kids. But by 2018, we actually had good data in children, and we were able to say, yes, this is an equivalent operation. I think in the new guidelines we're working on, the most important thing we're looking at is the fact that sleeve actually works better in children and young adults than it does in older adults. So the younger you are, the better your outcomes from a sleeve. And given that the complication rates are so much less than a bypass over a lifetime, it seems very important that we recognize the sleeve is the most common operation done in kids today. And that means that the rates of sleeve in kids are between 80 and 90%. So when we're talking about operating on children, we're doing it, we're doing sleeves, basically. The other thing that we've started to get data on, and there's been a lot of data published from 2012 to 2018. I mean, from 2018, sorry, to now. The other thing that we're getting a lot of data on is the age to operate. And there's no difference in younger versus older in terms of outcomes. But when you look at the sort of the social ability of a child to adjust to surgery, they actually do better at a younger age. So when we're doing like 10, 12 to 14-year-olds, they're having the best outcomes. And maybe it's because they are still in that age where they are listening to their parents and they take their vitamins or whatever. They haven't reached teens yet. They do really great. The next group is like the 14 to 17-year-olds also do really well. The worst time to operate on a kid is right before they go off to college. And unfortunately, that's a lot of the time when kids come to us because they're like, oh, I'm going off to college. I want to get an operation. But in my experience, there is no data on this yet. But in my experience, the 18-year-olds have a really difficult time going into the food insecure environment that is college dorms. And so we tend to operate on kids who are either 17 or 19 or are going to a community college and living at home, because there's a lot of issues with operating on that age group. So one thing that I hope to be able to say in the new guidelines is that there's clearly advantage to doing it younger. They have fewer complications. And then the other advantage is that if they've already developed a comorbidity, there's a lot of data in kids that diabetes, for example, is far more aggressive in children than it is in adults. So when we are talking about doing an operation on a child with diabetes, we want to do it as soon as possible because within 2 years, they're going to be on insulin. And within 5 years, it's not going to be reversible. And I've seen that in my practice. We see that in the data that they lose beta cells, like 30% of their beta cells every year after they develop type 2 diabetes. And so in kids, they develop retinopathy sooner, they develop renal failure sooner. It's a very aggressive disease, type 2 diabetes. So getting them to surgery sooner is hugely important. So our biggest challenge is pediatricians. It ends up that the most likely parent to bring their child in for bariatric surgery is one whose pediatrician has recommended it to them. And so we're trying to get the message out to pediatricians that this is a really good treatment for severe obesity in kids. And severe obesity affects 9% of the US population. 9% of children have severe obesity, meaning they qualify for surgery. And so far, we're only doing 0.001% of children with obesity are getting surgery every year, children who qualify. So it's a really small number of kids who need treatment and who need access to treatment are getting it. So I hope the new guidelines will help. The American Academy of Pediatrics came out with guidelines last year for treating pediatric obesity that made a huge splash and were terribly taken by the public, who was like, what, you're going to operate on kids with obesity? They went crazy. We expected it to be a very positive thing, but it ended up being quite different. And so it's not clear, we didn't see a drop in referrals at all, but we did see that it didn't have the effect we expected, was for a lot more referrals, because they did recommend bariatric surgery and medications. I do think it came at the same time as the GLP-1s were approved for use in kids, so maybe that had something to do with it. But the problem with GLP-1s in children is you're committing that child to that medication the rest of their life. And the cost of that is tremendous, even if the prices go down, even if it becomes an oral medication. The problem is that in order to have it cost effective, they have to be like 90% compliant, and they're not going to be. We know that about kids for sure. So if they're not compliant and they're on a medication for obesity, they're going to develop obesity again, or they're going to have a weight regain after weight loss. And that is psychologically devastating for children, for adults as well. But you can imagine a teen who's going through all of the body image issues, who is on a medication and either can't get it anymore because they've aged out of their parents' insurance, or they're not able to pay for it because the out-of-pocket pay even with Medicare can be very high. And those are the cases that I'm really concerned about medications in kids, because they don't have the long-term access to these medications. Over 60% of our patients are Medi-Cal, or in my case, Medi-Cal, but which is Medicaid. 60% are Medicaid on average across the country. And so kids with severe obesity are coming from, backgrounds where they don't have access to the medications and they don't have access to surgery always. So we're trying to improve that through advocacy, through the ASMBS, and through these guidelines, because I think the guidelines help direct parents, and hopefully will help direct pediatricians to counsel their kids, parent with obesity, and their parents about seeking surgery as an option. I often like to use, I'm going to keep talking. I often like to use the example of pediatricians sending a child for a tonsillectomy. So a tonsillectomy is a 1-hour operation. It has a risk of bleeding. It involves removal of a part of the body that is not going to go back, and it has permanent changes like in their voice, in their immunity. And so why would you send a child for that who has sleep apnea when you don't send a child for a sleeve, which is a 1-hour operation, has a risk of bleeding, basically the same exact risk factors, and yet it's just not part of their habits. And the main reason is because they still believe that obesity is related to eating too much and not exercising enough. And if you believe that, it's hard to send a kid for a surgery. And then the other thing is that, okay, when you go to get your tonsils out, do you worry about whether the child is assenting to the operation? Have you put that child through a psychological evaluation? Have you made that child do 1 billion tests and spend, at least 6 months working with a dietitian? I don't think so. And we know that, that's what we're making our kids do. And so I think, if you compare it to that and you get pediatricians to understand that, we should be sending kids for sleeve just like we do kids with sleep apnea for tonsillectomy. I think we can maybe move it forward a little bit. Now I'll stop and I'll take questions.
No, I think it's great, Dr. Pratt. I think it's great that you were able to compare it with a tonsillectomy. I wonder if a lot of the backlash against metabolic surgery for pediatrics comes from around that same time. And even now there has been the debate about gender affirming surgery for children and adolescents. And then this idea of body image and surgery, I think has a lot of pediatricians and parents and maybe just people in general up in arms about operating on children, but I hadn't thought about it like a tonsillectomy.
Yeah. Well, I see 25% in Oklahoma. That's probably the rate of obesity in kids, which is 30% nationwide. But severe obesity that actually qualify for surgery is 9% nationwide. It may be 25% in Oklahoma. I haven't been there recently. I hope not.
I have so many questions for you. I want to ask you about something before we get into the science of it. So I recently participated in or on a committee where we came up with guidelines, and it was such a huge undertaking. So I can only imagine what it was like. Can you maybe talk about that aspect of it? Because it was the first time I was being exposed to it, and I don't think I really recognized what I was signing up for. What was that like for you?
So guidelines, we started with our committee. The 2012 guidelines, basically I had done a huge lit search and then there had been a recent meta-analysis, and we basically took my guidelines from 2005 plus the meta-analysis that had been published and put them together for 2012. So we didn't do the extensive lit search and everything we did for 2018. In 2018, we went back to 2007 through 2018. It's a huge lit search. You come up with thousands of articles. And then basically we broke up into, we assigned each section to someone on the committee, and people volunteered, and one person would write a paragraph or two about, after reading all of the articles in their section. And then I rewrote the whole thing. Basically, once you get all that done, then you rewrite the whole thing, and then you go to committee. And then you meet and you decide what is the level of evidence, is this expert opinion, or is there actually evidence for this? And you go back to your articles, and as a committee, you literally go through every single point until you agree, and then it goes forward. And then it has to go to the EC and the other committees, and they send it back to you for edits. And it's a long process. Yeah. I think I had the 2018 guidelines was started in 2016. And so it was originally the 2016 guide, then it was the 2017 guidelines, so 2018 guidelines. And this current guideline was started in 2023, and it's now 2024, and it's certainly not going to be done until 2025 at best, if we're lucky.
Yeah.
So it is a lot of work, yes.
Well, thank you for doing it, because now we can look at it and consider how we should manage these patients. So my next question is for the fellows in particular, whenever we see or hear about a pediatric patient who has obesity, most of us are not going to be well, actually, maybe that is a part of the question. Is this something that you'd recommend someone who is taking care of adults with obesity start to introduce more pediatric patients into their practice, or how should we take care of these patients?
Yes, please. The more people are offering it to kids, the more we're going to have the ability to treat the volume of kids that need to be treated. I know, as having worked as an adult surgeon with a pediatric hospital, you know, in our center, I did both kids and adults for many years, and it's incredibly satisfying to help to operate on kids. The other thing is that you can partner with a pediatric hospital in your area. Just go to them, say, do you guys want to start a metabolic pediatric program? I'd love to come help and help them get started. There's nothing wrong with going over to the pediatric hospital. It's not going to be a huge volume. The largest volume pediatric hospital is doing 120 cases a year, and there's only one of them. So our hospital is the fifth largest or fourth largest in volume, and we're doing 50 cases a year. Okay, it's not going to kill your practice, and it gives you the opportunity to operate on your patients' kids, because your patients are the largest makers of obese children. Okay, so honestly, that's how I got started in it in 2005. You know, the parents were my patients were like saying, like, what about my kids? Can you help them? And I'm like, I don't know. And I started looking into it, and then by 2007, I was doing cases on kids at Mass General. And so I think, you know, the reason I started a program was because of that. And the reason I got into looking into the guidelines and everything was because my patients were coming to me and saying, can you help my children? Can you do something for my kids? And I think, you know, it runs in families, you know, it's genetic. We know that. In kids, there are some differences, though. And I think it's important, if you are going to start doing kids, is to understand those differences. One of the things that kids need is they need a pediatric hospital. There are things in pediatric hospitals that adult hospitals don't have. There's things like child life, which sounds like weird, but it's a really good thing. It's basically to help the kids get through the surgery safely and happily. There's a lot more resources usually for social workers, and kids need a different psychologist. They need different dietitians. They need a slightly different message than adults. And I think it's important to, if you're going to start doing pediatric surgery, to either involve a pediatric surgeon or to at least, you know, make sure that you understand like what ROHAD is, what Prader-Willi syndrome is, what Bardet-Biedl syndrome is. And I bet none of you have heard of ROHAD syndrome. And, you know, and these are the syndromic obesities that you need to know about. You need to recognize and make sure they're getting help for. And they do respond to surgery. So we do use surgery. Hypothalamic obesity is very common in our population. Those are kids who've had their hypothalamus usually removed because of a brain cancer. But there's a lot of other types of obesity in kids. And kids' obesity is really resistant to treatment with medications and with surgery. And, you know, we often use both to get them down to a normal weight. But the nice thing about the sleeve is you're going to be seeing these kids in the adult population too. So we've been doing these kids for 10 or 20 years. You're going to start seeing them come back, and they will have weight regain and they will need revisions. One of the interesting phenomena in children is that if you have a child who you do a sleeve on and 15, they come back and they're having reflux and they have inadequate weight loss or they have weight regain, if you do a bypass on that child, they lose a ton of weight. So bypass is actually very effective in children for inadequate weight loss, weight regain, or bile reflux. So it's different than the adult population. So I think that you have to kind of just understand the differences between kids and adults.
You mentioned a couple times medications, especially with the new anti-obesity medications. How do you use them in your practice with taking care of pediatric patients?
So before surgery, we try not to use GLP-1s. There's just not enough evidence that it doesn't affect outcomes of sleep. And in our practice, we have seen a lot of kids that are on GLP-1s pre-op. We have to restart them post-op. So for that reason, we try not to use GLP-1s pre-op if we can avoid it. Many kids are coming in on them now, so we're not going to be able to avoid it. And we will soon have data showing whether it makes a difference. We're very liberal with using Qsymia, which was recently FDA approved. It works really well in most kids. And it really curbs that appetite, which is hyperphagia is a huge part of genetic obesity. So it really helps with that. Most of our kids don't have contraindications to it, like hypertension. So we're able to use it in most kids. And then we use metformin when they're on antipsychotics because of the data on that is pretty good. But that's basically it. And usually we're using Wegovy or Ozempic. We can't use tirzepatide unless they are over 18. But the 18s and over, we will do the GLP-1 with GIP, Mounjaro or tirzepatide or whatever they're called. And we do use them post-op. So there's a lot of data that the post-op, they're synergistic. So, we'll have a kid who loses 14% of their total body weight, and that's all after a sleeve, and then they start rapidly regaining. And we put them on Wegovy, and they just take off, and they'll lose another like 18 to 20%. And so that kid's now lost, 35% of their total body weight, and they keep it off as long as they stay on the Wegovy. What we don't know long-term is if we can stop it. We don't know.
So are you in that group that believes that we should be treating with the medications early post-op? Like what's the earliest that you'll start?
We measured their weight loss. We offer it at 3 months if they've lost less than 10%, and at 6 months if they've lost less than 15%. And as soon as they nadir. So we offer it at 3 times.
What's like sorry, I feel like I'm monopolizing. So you guys jump in with questions. What's the youngest patient that you've operated on? Because we were talking about 10, even 10. Maybe.
Yeah, I think 11 is the youngest one I've done, and that his mom had bariatric surgery. The interesting thing, we looked at our patients 13 and younger and our patients over 13. And the main difference in the populations is that those 13 and under, 76% of their parents had bariatric surgery. And those in the older age group was only 30%. So I think that the most likely to bring in the younger kids are those who've already had bariatric surgery.
When you start that young, like how long do they follow up usually?
They're still following up. So I don't know. I guess, I try to keep them until they're like 26 if I can. And, I do a lot of the bypasses are on like 19, 20-year-olds. Technically, our program is we don't start kids who are 18 or above because MBSA QIP frowns upon that unless they have a disability. Or the children's hospitals are medical homes. So those who are transplant patients at the children's hospital and are still followed there, those that are, diabetes patients are still followed there. And then those with mental disabilities, severe autism, that sort of thing, that will follow as long as they'll let us, which is usually around 25, 26. Oops. Wrong one. Go for the phone.
Sorry, that was exactly what happened, and it was habit. I just clicked on my computer one without thinking. We've had a number of situations on the adult side with patients who have maybe not a diagnosed disability, but are really severely limited and have like a spouse who cares for them and does all the talking, all the decision making, all the cooking, all the appointments, everything. And we've really gone kind of back and forth about, should we operate on them? What if their spouse isn't there forever? Then what happens? Those kinds of things. So I'm curious with children with, things like severe autism or Prader-Willi or these other either genetic or kind of disability syndromes. What are your thoughts on that? How do you manage it? How do you decide whether surgery is appropriate?
So kids who have a severe disability like non-verbal or barely verbal autism or similar, and often it doesn't have a diagnosis, you know. What we do is we start by starting the program with them, and then we have two sort of tests that we do. One is we ask the caregiver to give them a liquid diet for a weekend and make sure that they are capable of following a liquid diet and being restricted from having solid food. And of course, it's going to be harder because they haven't had surgery yet. But that's the sort of the test to see, is the caregiver capable of making sure they don't eat solid foods? That's the first test. And the second test is we do a pre-op endoscopy in all the patients. So what we do is we bring them in for their pre-op endoscopy and we keep them overnight. And we make sure that they can tolerate an IV overnight without ripping it out. And if they can pass those two tests, and then we ask our ethics committee most often, then we go forward. The other thing that we try to make sure is that they have a backup caregiver. So if the mom is in an accident on the way to the hospital, is there a backup person prepared to take care of that child or that disabled adult in the case that you're asking? So you want to make sure, I think if you have those three things and the caregiver has gone through the program and knows what to feed them and seems to understand, then I think it's appropriate to do surgery. Again, it's like a tonsillectomy, you know. Do you really need a scent? I don't think you do. I think you need to know that they have obesity, which is a disease, and that they need treatment for it that's effective. And so I mean, from my perspective, I still think we should try to do it as long as we can do it safely. The other thing I like to see, although I don't think I've done one who didn't have this ability, is ability for them to say if they're in pain. So if they can communicate with their caregiver that they're having pain and where it is, that's very helpful too. Because I worry about doing it on someone who can't do that. So I don't think we've ever gotten through the tests anyway with any of the kids that couldn't communicate that. But that's another thing that I really like to have, is that they can communicate if they're in pain.
Yeah.
You did it again.
Ugh, I'm sorry. I'm very, I've got patterns in my brain. I was just going to say, I've also had some discussions with one of our pediatric urologists about spina bifida patients. Have you worked with them at all? Because I think that's a pretty interesting subcategory.
Yeah, I haven't worked specifically. We haven't done any of the spina bifida patients. We've had a couple of patients who haven't come to surgery, but who are achondroplastic dwarfism, who develop severe obesity. And I'm not really sure how that would work out yet, really, because we haven't operated on any. So I don't know what their weight loss would be like or if it would affect it. I think that, in the veteran population, certainly paraplegia or that sort of thing they don't get as good a weight loss, but they're also older. So if you do a sleeve on them, they might not necessarily see as good a weight loss as you would see someone who can exercise or move around.
Yeah, I think that's the challenge, is how much good exercise can you get with upper body only? But at the same time, it's so hard to be mobile if you don't have use of the lower half of your body, and
Right.
Any amount of weight loss is going to cut down on decubitus ulcers, increase mobility, make transfers easier, all of that stuff. So
I think the benefit outweighs the risk in most cases. I will say that the autistic patients do better, as do the ADHD patients, because they follow rules. So it's they actually do really well with following the post-op diet guidelines and just like sticking to it and being just because they're very methodical mostly. And so I found that, they tend to have really good outcomes.
I have a follow-up to Jean's question from earlier. So in our program, typically our adolescents stay in the program with lots of education for about 6 months or so. How long are you seeing the patients before you operate on them? And in what circumstances would you actually even extend that?
So we see them till they're ready, long story short. When I looked back at our data, it says the average time from their orientation session to surgery is 1 year. It was like 360 days. We're trying to decrease that, but the truth is that they need to go through at least 3 of we have group nutrition visits. So they need to attend an initial session where it's a teaching session. Then they attend the next month, they have a visit with me and our dietitian as an intake. And then the next month they do a group. And then the next month they do a second group, and they have to do 3 groups. And then they also have to get a sleep study, see a psychologist, see our social worker. So by the time we get everything done, usually it's 6 months before we're putting them on our board and deciding whether they can have surgery. Once they're cleared by our board, it takes another 2 months to get them to the OR. So honestly, it takes 8 to 12 months. But our program is designed to be 6 months. Does that work? No. But we're trying. You know, we work on it all the time. It's always something different that's delaying it. It's either the psychology visits because the psychologist is on maternity leave, or it's the sleep studies because one of the sleep labs closed, or it's always something. It's always something. Or the patient got sick and missed their visits. Patient got sick and didn't get their endoscopy done. They got sick and they couldn't do a sleep study, and that had to be rescheduled. So, they stay until they're ready. And, sometimes we do kids who've been in the program for 3 years. I saw a kid today who got pregnant after her first 3 months in our program, and now she's back. And that was 12 months ago.
There's a question in the chat from one of our attendees. Is there anything that you do differently, from a technical aspect when you operate on pediatric patients?
Yeah. So pediatric livers are really fragile, and their left lobe tends to be huge in kids with obesity. So I use a regular liver retractor. I don't do internal liver retraction because I just don't trust it. I'm worried that it'll just cut through the liver. Even the liver retractor sometimes cuts through the liver. So that's one thing. The second thing is, because it's so big, I don't go at Palmer's point with my Very's needle. I go lateral to Palmer's point. I go the anterior axillary line. And I know some people do this anyway, but I just go there. I call it Pratt's point just for the hell of it. Why not? I never named anything after myself, but it's Palmer, Pratt. I figured it would work. So it's anterior axillary line just below the rib cage. And there you don't hit anything. You can hit the spleen. I've done it once, but it's rare. And I've hit the liver going at Palmer's point. I've actually hit the liver over there too, believe it or not, that far lateral. I've hit the left lobe of the liver in kids. So that's one thing. I think the other major issues is that when you're doing a bypass, the pediatric intestine is very fragile. You have to be careful. You can't pull on it too hard. You have to be careful when you're counting the distances. It just, it doesn't tolerate graspers very well. And it's very easy to make holes in it. So I just say, treat it like a diabetic who's been diabetic for 20 years, okay? Because that's what it's like.
Steroids.
Yeah. And then sometimes you're working in a smaller space. So, kids haven't had pregnancies. They haven't had their weight cycling for years. So often the space we're working in is pretty small, and their spleens are huge anyway. So like baseline, they have large spleens, small space. It can be challenging. But, I think, otherwise it's basically adult technique. It's the same thing.
So same bougie size, same limb length.
Yes. Yes.
What are your thoughts on kind of on the adult side? There's all the talk about Barrett's and GERD and long-term risk of sleep. What are your thoughts on that for pediatric patients?
So we almost never see Barrett's in the pediatric population. And we do pre-op endoscopies on everybody. So out of 200 patients, I have 2 patients who I have changed my plan for a sleeve to a bypass based on esophageal pathology. We do see about 1 to 2% of patients have EOE, which we don't care about. We treat it. And then we don't do steroids or anything. We just do like PPIs, high dose. Then we rebiopsy them at the time of the sleeve. And if they still have EOE, then after the sleeve, we'll do steroids or whatever they need for it. So that's easy. Barrett's, I don't know. I did an endoscopy last week on a kid whose sister had Barrett's as a child and who has a bypass now. And this kid, I got in there, I'm like, oh my God, it looks like short segment Barrett's. I don't know if it is, but we'll find out. I did the biopsies, I don't have them back yet. So I think that's going to be the second one that I'm going to end up recommending a bypass for. But I do a bypass for them. If they have reflux, even if they have like some mild EOE or something, we treat them with sleeve, and I don't think it makes a difference post-op. Some of them have it after, some of them don't. Just variable. We don't see very many hiatal hernias. They're not common in the kids. I fixed maybe 3 out of 200. Really not common. So that's nice. You know, makes the sleeve pretty easy, straightforward.
I feel like I'm doing hiatals on.
Exactly right. Yeah. The kids don't have them yet.
But they won't if they have bariatric surgery.
Hopefully.
Early. Yeah.
Hopefully. So the 10-year teen labs data is really interesting. They broke it down into groups, and what they found is that 50% lose over 28% of their total body weight and keep it off long term. 50%. 10% regain the weight. So they may lose a little bit or not lose enough, and they regain it. And at 10 years, they're 10% above, 7% above where they were. Okay. And then there's this group in between. There's about 30% who fall in this group where they are going to maintain about 20% total body weight long term. They may lose about the same amount, but they're only going to maintain about 20% total body weight. And so it ends up at 6 months, you can tell which patients those are. And so we offer medications to anyone who's not in that 50% that's going to lose it and keep it off. And then those who are going to lose it and keep it off, but started at a BMI of 60 or a weight above 400, still may need medications just because they're not going to reach a normal weight.
I wish it was that adults.
There's a follow-up question about the technique. Do you also close mesenteric defects? Like, what's your position on that in a pediatric population?
Absolutely. I'd always close, because it doesn't matter pediatric or adult, I always close mesenteric defects. I don't have a robot at the Children's Hospital, so I'm handicapped in that way. So I do laparoscopic at the Children's Hospital, but I do it in the standard sort of robotic technique. I hand sew it. I do it. I do the loop first and the GJ first, and then I do the JJ in the left upper quadrant. And I find that I think that in my experience at the VA and doing that technique, that the risk of, as long as you close those defects, the risk of a internal hernia is fairly low. And I think it's really important to close Peterson's. It's really hard to do. You have to know how to do it. And I think a lot of people have different techniques. What I do is I just flip the roux limb over and I lift up the transverse mesocolon until it's right where my GJ anastomosis is. And then I just sew up the hole. And I use a purse string followed by a running suture. Everybody does it differently, but that's how I do it. And I use permanent suture, usually silk.
How about nutritional complications post-op in the pediatric population?
Yeah, so I've seen kids come in with B1 deficiency. It's horrible. They're there with their walkers and their eye patch, and which is how they treat double vision and the ataxia. And it's the last thing you want to see as a teen with that. And I actually published on this one teen that we had that was really severe, and it all reversed. But it can be non-reversible. So I think it's super important to stay on top of them with their B vitamins. We check their levels And if they're vomiting, I'm all over it. I'm like, okay, you need to, and we come in and we'll actually, if they're vomiting a lot, I'll bring them in for IV and an IV thiamine. But that doesn't happen very often. Most of them are pretty compliant. It's really important with kids to make sure that they have a way of taking the vitamins. So like we use neurobiome because it's sort of better tolerated than just B1 plain. And B1 plain just tastes so bad and it smells so bad. The kids are like, I'm not touching that. So I let them put it in cookie dough. I don't care what they put it in, anything to get it down their esophagus. And so, you just have to stay on top of it. We see them at like 2 weeks, at 6 weeks, at 3 months, at 6 months. And I do blood work at 3 months and 6 months. I check a folate, make sure they're actually taking their multivitamin. I'm very careful. They don't always show up, of course, there's no shows, but we do everything by telehealth. So our entire program is by telehealth because the average distance to our hospital is 2 hours by car. So because we take care of such a wide range of the California, Central Valley and Northern California, and other places, but those are the primary places, we do it all by telehealth. And that way we can take care of the kids in Sacramento and Eureka and everywhere else. And Reno. We do Reno too.
Do you have any kind of ways to have them get weight checks and stuff for telehealth? Do you just have them at home, or?
We make sure that they have a scale. The height is a real hard problem. So, it's hard to get the kids' height. So we ask them to see their pediatrician and get a height every once in a while, every 6 months or so. But they have a scale at home. And actually we just obtained funding. Yay, I got my grant to buy scales for the kids that can't afford them. So now every kid will definitely have a scale. So we're going to be providing scales, water bottles, pill boxes, and frisbees for every kid. And we won't give them a scale if they already have one because we don't want to waste our money. We really need to make sure that we're, putting it in the right place. But, if you have a kid that weighs 400 pounds, you might not have a scale that goes up that high. So we want to make sure that we can always get the weights because it has been a problem with some kids, especially those who are sort of Central Valley. Parents are in the fields. They don't have money. They just don't. No, I love your dog. Is it a corgi?
Oh yeah, this
Yeah.
is my one of my babies. I'm gonna have to start bringing her to ASMBS so that the other corgi can have a friend. I forget his name. The one who walks around.
Oh, I don't know.
Star of the show. Earlier we were talking about revisions in this particular population. And I think that, SADIs and duodenal switches are becoming a lot more popular. Is that something that you would do in a pediatric patient? So like, let's say you operated, early on, like 10 through 14, and they have weight recurrence, or obesity recurrence. Would you consider doing a SADI on those patients?
I think it's completely appropriate in some kids. I think that we try to get them to 18 and then send them over. So I've had 2 or 3 18-year-olds that I've sent for SADI because either parents had a switch or I just think that their weight is just, if their weight is over a BMI of 50 after a sleeve, I think you're right. I think a SADI is the right way to go. Or a DS. I don't think we know for sure. There is not a lot of data on it, but it looks like it's probably the best operation for Prader-Willi syndrome also. So if we start with a switch and then we start with a sleeve, get as much weight loss as possible, keep them stable, and then do a switch is probably better for them. I don't know what the right age is for that. I really don't. I worry about rickets. We worry about vitamin D deficiency.
Yeah.
Severe or vitamin A deficiency in the growing kid.
Yes. Mm-hmm.
So that's why I wait till 18, but is that the right age? I don't know.
Yeah. All right, we're a little over time. I would ask though, Ingrid, Juyeon, do you guys have any questions any burning questions?
No, I think this was great. I really appreciated the kind of the background information from everything we were looking at. I look forward to the new guidelines to see what happens next. I think I really appreciate it. As I said, the kind of the social aspects of what this might entail for adolescents, but I find it really interesting.
Awesome. Thank you so much. That was a great review. I really appreciate it. Well done.
Yeah, especially Ingrid, jumping in last minute.
Last minute, yes. She didn't have a
Great
lot of
job.
prep time.
Great job. There is one more question that popped up asking about specific pediatric specific complications, like what the rates are like. How often are you seeing those things like growth retardation and intellectual capabilities?
We don't see that as a complication of bariatric surgery. What we do see is complications are the same ones you see in adults, just less frequency. And we sometimes see childhood diseases like my most recent patient with a complication was admitted with salmonella a week post-op. I don't know, I don't think that's a complication of surgery necessarily, but the leak rates are very low. These kids heal well, and I think it's, the most common complication you're going to see is vitamin deficiencies, and they're less common in the sleeves than the bypass. Mm-hmm. So rarely see B12 deficiency unless we had it pre-op.
And I think, I could be wrong, but I think one of the things that was highlighted in the APA guidelines on the medical side is that the idea that bariatric surgery impairs bone growth and maturation is not true. Yeah. Just for fellows to know that children actually seem to grow more and faster when they've had bariatric surgery because the obesity actually does limit their growth metabolically. Is that accurate?
Yeah, they do get taller. The younger kids who have surgery get taller, reach a higher linear growth than those who have obesity and don't get surgery. So we do know that for the younger, for under 14. Over 14 doesn't really change their linear growth. They're not delayed. Obviously, there is a decrease in bone density in adults and kids who undergo bariatric surgery. And, we get them to take their calcium, but I think that part of the reason you see a decrease in bone density is because bone density is based on like your weight. Like if you weigh more, you're putting more weight on your bones, which we know if you lift weights, you have better bone density. So it's like, okay, so if you lose weight, you're going to have less bone density because that's normal. But it's unclear how much is normal, how much they should lose versus how much they do lose, and whether it's going to have any effect long term on their bone, their risk of fractures. I don't think so, but that's going to take 70 years for us to know.
Are you measuring bone density on any of your patients? Not just pediatric, I guess in general.
We do a DEXA pre-op on all the PD patients. And some of that is to confirm that they have obesity, because we don't want to especially, the ones that are that have dwarfism or some other genetic thing, you don't know if their height and weight is normal for them or you don't know what percent is body fat. So we do a DEXA scan with total percent body fat. And we make sure that that's also abnormal before we recommend surgery.
As you can see, Dr. Pratt, we could stay here talking with you all night.
All right.
But we're well over time. So thank you again for taking the time to talk with us about the guidelines. Thanks to Ingrid for preparing the presentation. Laura, you are my partner in crime. Thank you. Juyeon, we are looking to all the wonderful things that you and Faiz will do over the next couple of years. And again, thanks to the ASMBS staff for supporting us. All right, guys, have a good night. Enjoy your weekend. We'll see you back
Thank you, everybody.
on 1 of August.
Thank you for having me. Bye.